This is a contrast CT scan of a 21 years old female patient. She has got focal pancreatitis involving tail and the lateral part of body of pancreas. Now, this is the area of involvement of the pancreas by the acute pancreatitis. Now, this is the pancreatic duct which is dilated. The tail and adjacent lateral part of body of pancreas, these show non-homogeneous enhancements. Density of peripancreatic fat is increased. As such, there is no area of necrosis inside the involved pancreas. Now please observe the increased density of fat along the greater curvature of stomach. Low down along the medial side of spleen, there is no narrowing or occlusion or thrombosis of the splenic vein or splenic artery. Now this is the increased density of fat in left anterior perineal fascia. This is small fluid collection here showing wall enhancement. This may represent a small abscess here. The anterior parallel fascia and lateroconal ligaments, now these are thickened. The reason for sharing this case is that I just want to show you and highlight how colon cutoff sign occurs in cases of the acute pancreatitis. Now this, please observe, this is the transverse colon here, Sayre field. Now at this level onwards, now this is the splenic flexure of colon. Please observe the edema and thickening of wall of the splenic flexure of colon. Please observe the thickened wall, edematous. Now, although we cannot see the phrenico-colic ligament, but the other ligaments which are also present here, that is lienorenal ligament and lienogastric ligaments, they are all thickened and waterlogged by the presence of fluid attenuation areas here or increased density of the fat because of excessive fluid accumulations here. Now please observe that this is the descending colon, it is collapsed. This is what happens in cases of acute pancreatitis. I scroll it back up again. Please observe fluid attenuation areas, increased density of fat in the anterior perineal space, waterlogged and edematous splenic flexure of colon. This one here. The jejunal valvulae conniventes, they are also thickened, suggestive of edema. There is a small transient intussusception here, this one here, this one. This is the coronal scan. Now this is the transverse colon here. Please follow the splenic flexure. This is the thick-walled edematous splenic flexure. This was the tail of pancreas with dilated pancreatic duct. Now this is the collapsed descending colon. The rest of the body and head of pancreas, these one here, they are normal. This is the normal looking pancreatic duct. In the regions of the body and head of pancreas, no inflammation there. In such cases, we should look carefully for any intraductal calculus, but unfortunately we couldn't find any intraductal mass lesion which was obstructing the pancreatic duct, resulting in dilatation of the pancreatic duct in the regions of the tail of pancreas, resulting in focal pancreatitis. ERCP of this patient was also done, which reported narrowed pancreatic duct in the region of the lateral part of body of pancreas. There was no comment upon the dilatation of pancreatic duct in the region of the tail of pancreas. Now this is the pancreatic duct. We must trace it carefully medially towards the body. We couldn't find any radiopaque calculus here or any intraductal mass in this region. Now this is the rest of the body and the head of pancreas, which are normal looking. Gallbladder is normal.